Welcome to From the Experts, All Things Celiac. Today's webinar is Unbalanced Eating, the Spectrum of Eating Disorders with Gluten-Related Conditions, hosted by the National Celiac Association and the Harvard Medical School Celiac Research Program. The Harvard Medical School Celiac Research Program was founded in 2013 by celiac experts from 3 Boston hospitals: Dr. Alan Leichner of Boston Children's Hospital, Dr. Karen Kelly of Beth Israel Deaconess Medical Center, and Dr. Alessio Fasano of Mass General Hospital. The highly collaborative Harvard Medical School program has a twofold mission of developing and promoting the latest research in celiac disease and advancing awareness about celiac disease through educational programs to clinicians and to the general public. I'm Lee Graham, Executive Director of the National Celiac Association, celebrating our 30th year serving the gluten-free community. National Celiac provides educational resources on our website like Ask the Dietitian, Raising Our Celiac Kids, and Supporting Celiac Seniors. Zoom interactive meetings are open to all on the second Tuesday of every month. And my thanks to all of you for continuing to support our food insecurity initiative, Feeding Gluten-Free. Thanks to you, we are now delivering gluten-free food to food pantries in over 3,000 communities across the United States. For today, you are welcome to ask general questions through the Q&A feature, which is located on the bottom right corner of your Zoom screen. Closed caption is available by clicking on the CC button. For those of you who have registered for continuing education units, please fill out the survey that will be added to the chat box during the webinar. If you are still struggling to connect with us, tech support is available if needed at digitalmedia@partners.org or by phone 857-282-6470. Also, this session is being recorded and will be available for viewing on National Celiac's website, nationalceliac.org. Our moderator today is Melinda Dennis. Melinda Dennis is a registered dietitian and co-founder of the Celiac Center at Beth Israel Deaconess Medical Center in Boston, where she serves as the nutritional coordinator. Diagnosed with celiac disease 32 years ago, Melinda specializes in medical nutrition therapy for patients with gluten-related disorders and through teaching online classes to patients of Celiac Center at the Celiac Center. She serves on the executive committee of the Celiac Research Program at Harvard Medical School and is involved in the planning and implementation of the Ask the Experts All Things Celiac webinars with the National Celiac Association. Melinda is program director of MIDMC's nutritional and medical website, celiacnow.org, and founder, former chair, and current senior nutrition advisor to NCA. She is involved in several research studies and serves as a task force member on consulting projects related to improving the life of those with celiac disease. Welcome, Melinda Dennis.
Thank you, Lee. Thank you so much. Welcome, everybody. Thank you to NCA. Thank you to Harvard Medical School Celiac Research Program. And our webinar topic today, Unbalanced Eating, the Spectrum of Eating Disorders with Gluten-Related Conditions, is a very prominent issue. Gluten-related disorders getting much more attention these days in clinic and in research. I'd like to add that a research article just came out, which features the work of one of our speakers today, Dr. Mrs. Satherley. So, just housekeeping. Please use the Q&A feature for only general questions, not for specific medical ones. And the session will be recorded, of course, and you can find it later on nationalceliac.org/webinars. CEUs are available for registered dietitians, nurses, physicians, and social workers, and for those who are pre-registered for the webinar. And to receive your CEUs, be sure to fill out the survey that Vanessa has placed in the chat. I would love to introduce our first speaker, Dr. Rosie Satherley, and ask her to share her screen, please, Rosie. We are so eager to welcome you today. Rosie Satherley is a lecturer in clinical psychology at the University of Surrey in England. Dr. Satherley completed her PhD at the University of Birmingham, where she started a program of work on the complex relationships between celiac disease, the gluten-free diet, and well-being. She has an interest in the different approaches to managing the gluten-free diet and the relationship between hypervigilant approaches to dietary management and disordered eating. Some of her research is currently being funded by Celiac UK, which focuses on developing psychological support for children with celiac. Thanks, Dr. Satherley.
Thank you, Melinda. And can I just check you can all see the slides?
Yes, we can.
Excellent. Well, thank you for inviting me today. It's such an honor to be here. As Melinda said, my name's Rosie Satherley, or Rosemary, if we want to be really, really formal, but no one calls me that. And today I'm going to talk about gluten-related disorders and relationships with food. But first of all, some disclaimers. So my work involves the training of clinical psychologists and conducting research on the psychological impact of long-term conditions, with a lot of my work in celiac disease. I'm not a clinician, I'm a psychological researcher. Some of my work that I'll be talking about today, as Melinda kindly said, has been funded by Celiac UK and the University of Surrey. So let's have a think and a pause to consider our relationship with food. Now, we don't typically stop to think about the role of food in our lives, but actually, if we do stop and think, food is so much more than fuel for our body. Our relationships with food are actually incredibly complex. So let's just have a little bit about a think about what this means for all of us. We all have different relationships with food. So thinking through these questions, these answers will all be unique to you, and there are no right or wrong answers. But when we think about our relationship with food, these are some questions you might consider. So do you have any rules around food? For example, finishing eating your plate or eating dinner at a certain time. Does your culture or heritage impact your food choices? So certainly, as someone living in England, I drink a lot of English breakfast tea and get very upset if I don't have access to my tea. Do you have any happy or sad memories of food? Often for people, food ties people together at festivals, gatherings within the family or the workplace. And all these reasons are why following a gluten-free diet can be hard, as it affects social relationships, can challenge our culture and expectations around food. So I think this diagram figure highlights this really nicely. So there are lots of things we might want from food, but there are some things that can jeopardize this. Now, this might be finances. Gluten-free food is more expensive than gluten-containing food. It might be time to cook a meal in the evening. It might be body image, and it might be the gluten-free diet. So let's talk about the gluten-free diet a little bit more. So most people in this room will need to follow a gluten-free diet. So you might have been told you must follow a gluten-free diet, and gluten will make you very, very unwell. Now, this is really challenging, and it can really change our relationship with food. Now, whilst we can't stop the need to follow a strict gluten-free diet, we can think about how to build this into our relationship with food. So in the content of being told that gluten is dangerous or harmful, it kind of makes sense that some people with gluten-related disorders have a level of worry, caution, or anxiety around food in general. This is just our body adapting and making sure we don't consume something that's dangerous for us. So to think about this a little bit more, there are several sort of pinch points along most people's journeys with gluten-related disorders, where relationships with food, worry, concern, and anxieties around food can become challenging. So firstly, we've got pre-diagnosis. Often we're quite uncertain of what symptoms might be. We might be aware that they're related to food, and this sort of uncertainty can last years and encourage concern around food. Eventually, we might get to the point of diagnosis of a gluten-related disorder, and while this may come as a relief to many, for some, they might be uncertain about what gluten is, how do I avoid it, and also do I really need to avoid it? Then you've often got the introduction to the gluten-free diet, which can feel overwhelming for some, and it's important to develop a confidence and competence in identifying gluten-free foods, but this can come with some concern and worry, particularly around identifying gluten-free foods outside the home. And then we all have transition periods in our life. So for young people, this might be their transition to independence and making their own food choices. For adults, this might be transition to a new town where you need to find the local gluten-free restaurants, or a new workplace, or even navigating a new relationship. All these things can make the gluten-free diet and caution around food very challenging. And then we've also got to maintain self-care and follow a gluten-free diet. And unfortunately, sometimes an accidental exposure is going to happen. Actually, it kind of makes sense that if we're accidentally exposed, we might think a bit more about food and be a little bit more cautious for a short time. So the point of this is to show it's very normal and even helpful for our bodies to develop a caution around food at these pinch points. But when concern and anxiety becomes embedded into our everyday lives and it becomes long-lasting and entrenched, further support might be required. So to add another sort of complication, sometimes for some people, there's symptom overlap between anxiety and gluten-related disorders. So it's important to be able to disentangle the physical sensations of a reaction to gluten and anxiety. So am I experiencing anxiety or am I experiencing gluten contamination? Now, because anxiety and symptoms of gluten-related disorders are so closely linked, and we've got these pinch points in most people's journey to diagnosis, this can make following a gluten-free diet challenging. So a gluten-free diet is essential to promote the health of people with gluten-related disorders, but there is a balance. We need to manage anxiety and quality of life whilst eating gluten-free. So unfortunately, this sort of occurs on a spectrum. Some people, if you look at your left hand of your screen, might not have enough worry and might not have enough assessment to risk and might accidentally consume gluten-containing foods. And then at the other end of the spectrum, on the right-hand side of your screen, you've got some people with real high stress, anxiety, and worry, and what we're now calling a hypervigilance regarding risk and an impaired quality of life. So these people might be, for example, afraid to eat outside the home because that causes concern around consuming gluten. Now, what we're hoping most people with gluten-related disorders can achieve is a good level of confidence, knowledge, and understanding of risk, able to follow the gluten-free diet with a balanced quality of life and relationship with food. Now, hypervigilance is a term that's sort of thrown around a lot at the moment. Now, unfortunately, we don't actually know a lot about hypervigilance in gluten-related disorders. It's a very new concept, but broadly, it's when anxiety around food impacts quality of life and well-being. Now, we don't know how common this is, but some studies suggest that up to 50% of adolescents with celiac disease will experience what people are calling hypervigilance. So this might look like rigidity around food, very controlling behaviours around food, and a real preoccupation with food and impaired quality of life. Now, unsurprisingly, hypervigilance in celiac disease is linked to intestinal recovery. Of course it is, because these people are following their diet really, really well. So to a clinician, this might look like, actually, the patient is following their diet perfectly. I don't need to provide any more support. But there's sort of a hidden increased psychological distress and impaired well-being associated with hypervigilance. And there's also an increased risk of disordered eating, which we'll talk more about later. So a few years ago, I developed an assessment tool to try and identify these sort of hypervigilant concerns around eating behaviours in people with gluten-related disorders. So there are an example of some of the questions in this tool here. This tool is free for clinicians to use, and you may want to consider these questions if you're someone living with a gluten-related disorder. They ask things about, are you afraid to eat outside the home? Are you afraid to touch gluten-containing foods? Do you find it hard to go to social events involving food? So this screening tool might be helpful to identify people struggling with hypervigilance in clinical practice, but it's a new tool and it needs a lot more work. So please use with caution. And if you see any research looking at this tool, do get involved to help us make it better. One of the psychologists I'm currently working with, called Heather Madison Roberts at the University of Surrey, she's currently adapting this for use with children and young people. So in a few months, we'll be able to show you a new version of this tool that asks questions about school and what's it like eating in friends' parents' houses. So I just wanted to try and show you what hypervigilance looks like, and sometimes this hypervigilance around gluten really impacts our relationship with food, that it might lead into something called disordered eating. Now, these examples on the screen, I think, are quite clear examples of hypervigilance because they're impacting quality of life. And actually, for some people, I see it impacts medication usage, ability to work, ability to eat any foods at all, or actually an ability to only eat certain types of food, so foods that the individual thinks are safe for them. So let's have a little discussion about disordered eating. So hypervigilance and disordered eating are linked, But first things first, I think we are all in agreement that gluten-related conditions are not an eating disorder. They are caused by a physiological reaction when we consume gluten. However, because gluten avoidance can be very challenging, some people with gluten-related disorders have a challenging relationship with food, and this may develop into disordered eating or a clinically significant eating disorder. But most people with a gluten-related disorder work hard and can work hard to have a good and happy and healthy relationship with food. So this picture shows the sort of how I view the spectrum of eating disorders and disordered eating. So in the green box, you might call this healthy eating. I say that in inverted commas because no one's healthy all the time. But healthy eating is when someone feels they have a good relationship with food, they have good nutrition and a healthy weight for age, height, and body type. Now, on the other end of the screen, you've got the red box. This is your clinically significant eating disorders. So it might include anorexia nervosa, bulimia nervosa, binge eating disorder. Now, clinically significant eating disorders are more prevalent in those with gluten-related disorders, but actually it's only about 1.6 times more prevalent. And the focus has really been on those sort of restrictive eating behaviours like anorexia nervosa, but we also see the same with binge eating disorder. Most people with gluten-related disorders will fall into the yellow box, and this is what I call disordered eating. So this is a real focus on food. It's a preoccupation with weight and shape. It might include obsessive overeating or restricting food intake. Now, this also might include the concept of hypervigilance. This is where I think it's really important we understand more, because if you intervene when people are in the yellow box, they're then less likely to progress on to the red box. So disordered eating and eating disorders have a huge impact on individuals and the family. They're linked with impaired family function, so more arguments, anger, frustration, impaired quality of life, so social relationships, work life, school life, and increased risk of mental health impairments. So that might include things like anxiety and depression. Now, unfortunately, when we think about support for our relationships with food and gluten-related disorders, at the moment, there is not a lot out there. However, I think we can think of support as a toolbox, and there are lots of tools that can help people live with gluten-related disorders and have a better relationship with food. So most people with a gluten-related disorder are managing their gluten-free diet well and their quality of life well. This doesn't come easy. It comes from putting in really hard work and seeking support. Some people with a gluten-related disorder will need specialist support from a mental health professional, but not everyone. But I do think everyone can benefit from a range of psychological tools. So there are several tools that can help us live with the gluten-free diet. And these tools include your own experiences, your healthcare team, your friends, your family, your pets, as well as a range of psychological tools, which I'm going to talk to you a little bit more about now. So the first and one of the most important psychological tools is your friends and family. Social support is really important for those with gluten-related disorders or any long-term condition. It can be through other people with gluten-related disorders. Social support can also be through people without gluten-related disorders. Social support is about disclosing with people and sharing information with people. So social support is effective in improving quality of life and gluten-free diet adherence. It's also effective in preventing the development of eating disorders. So this can be both online and offline. And social support doesn't have to be around food. So there's a lot of gluten-related groups that are about food. That's not what social support is. It might partly be that, but you can get social support through a dog walk in the park if that's helpful for you. So the next psychological tool, apologies for the screen sharing issue there, is your healthcare team. So follow up with a healthcare provider is associated with improvements in gluten-free diet management and well-being. And it doesn't really matter who the healthcare provider is. It might be a dietitian, a gastroenterologist, a social worker, a nurse, can be a psychologist. And what I would recommend, there aren't a lot of psychologists who are familiar with gastrointestinal conditions. If you are looking for specific support from a psychologist, have a look at the website I've linked here, the Rome criteria. That has a list of providers across the states. The important thing though, if you're seeing any healthcare provider, make sure you're asking them the right questions. So I would suggest using something like the iceberg tool. So the iceberg tool shows us, if you go to clinic and someone asks, how's your gluten-free diet going? Yeah, it's fine. The healthcare provider is only getting the surface of your iceberg. They're only getting the surface of the problem, and they don't understand what's going on beneath the surface. So have a sit down, and if it's with your child or yourself or family members, and think about what's going on for each of us individually, and bring this sort of iceberg tool to your clinic to open up conversations, open up what's below the surface. You can also use this between parent and child to work out what's going on for your child. And the last psychological tool is, of course, psychology itself. Now, it's really important to say there is no magic in psychology. You don't just see a psychologist and feel better, and a psychologist does not have a way of working that just magically fixes things. For gluten-related disorders, we don't yet know what psychological approaches work for who. This is a very new area of research. There's a really rigorous science behind this, and this science and research is really important because there's evidence that if we provide the wrong psychological intervention, it can do more harm than good. So there is some evidence for cognitive behavioral therapy for celiac disease specifically, but again, it's very new evidence. So what I say is have a look at research in this area. So at the University of Surrey, I'm currently funded by Celiac UK to develop at-home psychological resources for children and young people with celiac disease. So follow our Twitter pages and you'll see when we're delivering out those and testing those. And one of our psychologists, Imogen Hughes, is currently testing a cognitive behavioral therapy intervention that's delivered online for adults with celiac disease. So this is a new area. If you want to help us develop the evidence base, please keep an eye out for our research studies. Thank you very much.
Dr. Satherley, thank you so much. It was wonderful. Now I'd like to reach out and introduce Dr. Elana Bern. And Dr. Bern, please feel free to share your side. Elana Bern is an attending gastroenterologist in the Division of Gastroenterology, Hepatology, and Nutrition at Boston Children's Hospital and an assistant professor at Harvard Medical School. Dr. Bern's GI fellowship was at Children's Hospital of Philadelphia and Tufts Floating Hospital for Children. During her GI fellowship, she earned an MPH, Master's of Public Health, at Harvard School of Public Health. Following the fellowship, she was an attending physician in GI at the University of Massachusetts Medical Center. She joined the Division of GI at Children's in 2002 and has a long-standing interest in the impact of feeding and eating disorders on children through their developmental milestones. She chaired the committee to develop the Boston Children's Hospital ARFID inpatient clinic pathway and spearheaded the development of the multidisciplinary ARFID outpatient program, where she serves as co-director. So we'll hear much more about ARFID. Thank you, Dr. Bern.
Thank you. It's an honor to speak. Can you all hear me? Yes? Okay, sorry.
Thank you.
Okay, today I'm going to talk about gluten-related disorders and eating disorders at the crossroads. My disclosure is Abbott Pharmaceutical provided support for presentation on ARFID in June 2022. The content of the presentation was my own. So let's start with gluten-related disorders. Consist of celiac disease and gluten sensitivity. Celiac disease, as you know, is an autoimmune disease where the GI symptoms and inflammation of the small intestine are triggered by eating foods containing gluten. Gluten sensitivity, you have GI symptoms triggered by eating foods containing gluten. An eating disorder is a disturbance of eating behavior impairing physical and/or mental health. So let's think about the new faces of eating disorder. Well, in 2013, the American Psychiatric Association published the DSM-5, which is the Diagnostic and Statistical Manual of Mental Disorders. And basically, the goal of the authors was to reclassify eating disorders in a way that made clinical sense. And so one of the new classifications was Avoidant Restrictive Food Intake Disorder, or ARFID, as you see here. So what is ARFID? Well, let's go through the DSM-5 criteria. ARFID is an eating or feeding disturbance with persistent failure to meet appropriate nutritional and/or energy needs associated with one or more of the following: weight loss or faltering growth, nutritional deficiency, dependence on enteral oral supplements, and/or marked interference with psychosocial functioning. It cannot be explained by lack of food or culturally sanctioned practice. It is not associated with body image disturbance, and it's not explained by other medical or psychological conditions. So ARFID is not just picky eating. Picky eating is disliking one food, maybe even a few foods. But at the other extreme is ARFID, where you dislike and you avoid most foods. In picky eating, there's no harm done to the body. The body functions fine. In ARFID, there's a risk of the body can take a serious toll from this restricted eating. You can have malnutrition, micronutrient deficiencies, stunted growth, pubertal delay, and social impairment. There are 3 subtypes of ARFID that we think about, and often they can overlap. There are individuals who do not eat enough and show little interest in eating. These individuals, the parents may say that they've never had an appetite. They had to remind their child to eat, otherwise they would never eat. Individuals who only accept a limited diet in relation to sensory features. Those individuals often narrow their diet related to texture, are brand specific, maybe color, temperature specific. And then there's individuals whose food refusal is related to aversive experience. So they may have had a choking episode or vomiting or abdominal pain. And this has been associated with discomfort with eating. And so now they begin to refuse food because they're afraid to eat. Jenny Thomas and Cameron Eddy conceptualized this ARFID cycle, which I think is really helpful for us to understand ARFID and also figure out where we can intervene. So individuals with ARFID often have a biological predisposition. They may have been born, they may have autism, they may have increased anxiety, decreased appetite from an early age, or sensory sensitivities. And in some proportion of those individuals, they may experience a food-related trauma. As we said, it could be celiac disease. It could be, choking or a vomiting episode. And then they develop negative feelings and predictions about the consequences of eating, that every time I eat, something bad is going to happen or I'm not going to feel good. And this results in food restriction. They often will reduce their volume of the food they eat and or the variety of food. And again, this is a patient choice restriction, but also you can get what's called caregiver accommodation, where the parents will give the food to the child that the food wants to eat, or allow them to what we call graze, meaning eating small amounts throughout the day. And this results in short-term reduction of the child distress, but allows for continued food avoidance. And in the end, you end up with nutritional compromise with a very narrow diet and often limited social opportunities for exposure. And as a result, the cycle then goes back where, as a result of all that, you restrict even further because you're fearful, which results in further negative feelings and predictions about consequences of eating. And so the goal is really to break this cycle. So thinking about gluten-related disorders and ARFID and where the two shall meet. Well, you can have ARFID from a really early age, and then you just happen to develop later in life a gluten-related disorder. So now you have both. Or you can have a gluten-related disorder, develop GI symptoms, abdominal pain, diarrhea with eating gluten, and you become fearful of eating. And in the susceptible individual, that person may develop ARFID. And so now they again have ARFID and gluten-related disorder. The messaging is very conflicting with these two. So with gluten-related disorder, the goal is to eat a strict gluten-free diet. So the message is pay attention to everything you eat. Make sure that there's no gluten in your diet. In ARFID, it's a self-imposed restricted diet. So the message is liberalize. We want you to reduce the anxiety with eating, expand your diet. And so you can see how it can be very conflicting. How do you pay attention to everything you eat, but also relax and liberalize and not be anxious about eating? So it can be really tough. Now let's focus on assessment and treatment of patients with ARFID. Our goal are really 3 prongs. One is to identify and treat underlying triggers and comorbidities, because that's really important in order to effectively treat ARFID. Identify, reverse malnutrition, micronutrient deficiencies, and normalize growth. And identify and reduce psychosocial impairment, which we know often exists. So in terms of looking at and addressing underlying disorders, as a clinician, we look at, are there any underlying disorders that could be contributing to the food refusal? Could there be gluten-related disorder? Could there be celiac disease? Could there be what we call eosinophilic gastrointestinal disease? Could there be inflammatory bowel disease, let's say Crohn's disease, or gastroesophageal reflux disease, irritable bowel syndrome? Is there something else that we need to be treating to help reduce the need to refuse food? And then there's looking at non-GI disorders. And again, these are just a few: enlarged tonsils, dental caries, aspiration or feeding discoordination, and any chronic disease that makes it uncomfortable for you to eat. And then it's important to look at the comorbidities in mental health. Is there anxiety? Is there depression? Is there obsessive compulsive disorder? Is there autism? And what is primary problem and what is secondary due to ARFID? Nutrition is really important for our bodies. And this is the myplate.gov. And a balanced diet consists of fruits and vegetables and grains and protein and dairy. This, on the other hand, is a typical ARFID diet. And you can see here, you see chicken nuggets and French fries and fried onion rings. You don't see fruits, you don't see vegetables, you don't see dairy. Often there's very little protein, and usually it's processed carbohydrates, not whole grain foods. This is called a chronometer, and it's a way for our dietitians to basically quantify the nutrients in a person's diet. And you can see this is a patient of mine with ARFID, and you can see it looks at vitamins and minerals, carbohydrates, lipid, and protein. And what you see is in this patient, and I have many patients like this, they're very low in vitamins. B vitamins are very low, vitamin A, vitamin D, vitamin E, vitamin K. In this case, the patient drank a lot of juice, so the vitamin C is high, but often vitamin C is very low. Minerals are often low: calcium, copper, iron, zinc. The fiber is often very low, and the protein is often very low. And then when you add, and here's the ARFID diet, and here's the gluten-free diet. And when you add the ARFID diet and the gluten-free diet, you get a diet that is often low in vitamins and minerals, low in protein, low in fiber, low or high in calories, high in saturated fat, high in sodium, and high in sugar. And so you can imagine, again, if you eat this kind of diet day in and day out, it can take a serious toll on the body. You can end up with low or high weight, stunted growth, pubertal delay, micronutrient deficiencies, micronutrient toxicities because you're eating the same food over and over, and low bone mineral density. So this was an article written by Harshman et al. That looked at the diet of youth with ARFID, and they found that the diet is high in processed foods, total carbohydrates and sugars, and low in vegetables and protein. And that's not surprising given what I showed you. This was an article that was published and picked up by the lay press in Newsweek. A teenager who went blind after only eating fries, chips, white bread, sausage, and ham since elementary school. And this was due to multiple vitamin deficiencies. This is a publication from Boston Children's Hospital of 7 children with autism who presented with limping to our emergency room. And it turned out that they had scurvy or vitamin C deficiency. They ate no fruits or vegetables, and they didn't take a multivitamin. And then this is a report of what we call subacute combined degeneration of the spinal cord. Again, due to ARFID in an individual who basically was very vitamin deficient in multiple vitamins. And this is basically talking about micronutrient toxicities. I have a few patients who really only eat baby foods and eat many, many jars of them. And this is just to remind us that anything in excess can be harmful to us. And then bone mineral density. We know that in ARFID as well as anorexia, the bone mineral density can be low, putting these individuals at risk for osteoporosis. And we know in celiac disease, it can be low. So again, a diet that's healthy is really important with a complete multivitamin. And then there's the social concerns, which are also really important to the individual and to the family. Having ARFID and gluten-related disorders and eating with others can be hard. It can affect traveling. It can affect going in public or to school, going to a friend's houses, family get-togethers. It can be really tough. So how do we exit this cycle? Well, for one, we have to think about we are social beings. So we want to reframe. We want to think beyond the gluten-free meal together, engage in other social activities. It doesn't have to be related to eating gluten-free foods together. And then there are several behavioral approaches that we know can be helpful in ARFID, and I'm going to talk a little bit about a couple of them. One is we want to optimize appetite, which is inherent and key, and pleasure. And this we're going to talk about mealtime structure and environment. And we want to work on expanding food and social interactions. And you can use food chaining and something called cognitive behavioral therapy for ARFID. So mealtime structure and environment is really important. We have an intrinsic sort of inherent appetite, most of us. But if you eat all the time or you graze, that disappears. And so in the end, you end up eating less and often losing weight. So setting up consistent sleep-wake time, consistent meal snack schedule, removing access to snacks 90 minutes before meals, and keeping meal times to 30 minutes. So you have an opportunity to get hungry and not bored with eating. Eat meals and snacks at the table, not in their bedroom alone. Turn off screens and eliminate other distractions. Make it fun and focusing on the food and that it tastes good. And enjoy mealtime. Eat as a family whenever possible to make it a fun experience, not a chore. Food chaining is very helpful for ARFID. It's what we call reimagining eating. So again, because these individuals have such a narrowed specific diet, the idea is take the food they already are comfortable with and then modify it just a little bit, one step at a time, so that eventually they're onto a new food. And so you can modify by sensory components, the shape, the color, the taste, the smell, the temperature. And one example is you take a child who likes potato chips. Now you're going to offer banana chips. They can be similar color, texture, shape, but they're a little different. And then you offer a frozen sliced banana. And then you offer a sliced banana. And that slow change is something that the child may be, or the individual may be more willing to accept. And then over time, the quote, non-comfort food becomes another comfort food.
Excuse me, Dr. Bern, you have 3 minutes.
Okay. Cognitive behavioral intervention techniques. Let's talk about the premise here. So on the y-axis is what you call subjective units of distress. There's alert on the bottom and there's high anxiety on top. Well, when we avoid, let's look at that first. So let's say we try to eat a food, we become very anxious. So we take the food away. Our anxiety diminishes. Phew, it's a good thing I didn't eat that. But then the next time you're exposed, your anxiety goes up. So in cognitive behavioral, in CBTAR, cognitive behavioral therapy, we want you to ride the wave. So you're exposed and then you sit with that and you learn to feel comfortable and you realize the anxiety will diminish on its own. The next time you're exposed, there's less anxiety. And the next time you're exposed, there's even less anxiety. And so with each repeated exposure, the anxiety diminishes. And you get expansion of diet and social interactions you can do related to social eating too. So for future research, I just want to introduce, there are a couple of really exciting research opportunities out there. One is cognitive behavioral therapy for ARFID. This was a study that was published by Jenny Thomas. It's a proof of concept pilot study in children with adolescents using cognitive behavioral therapy. And what you notice is that they added 16 new foods and 70% no longer met criteria for ARFID at the end of the sessions. Similarly, a study was done like this, a pilot study in adults. And also 18 new foods were added and 47% revealed no longer met criteria for ARFID. Feeling and Body Investigators is a study that was published by Nancy Zucker, and it's basically using interoceptive exposure treatment for children with the ideas you can see here of playful cartoons and developmentally sensitive exposures to teach children how to map interoceptive sensations and basically expand their diet. And then there's the SPACE ARFID. This is a pilot trial of novel parent-based treatment for ARFID with the goal of increasing food-related flexibility. And I'm sure you'll hear more about these in the near future. And so lessons learned, gluten-related disorders and gluten-free diet, there's a risk of hypervigilance and food preoccupation and ARFID in the susceptible person. So you need to think about and identify and help them. Gluten-related disorders, food is not dichotomous, good or bad, but rather safe and healthy. The social supports for gluten-related disorders, think beyond the mealtime for patients with ARFID. And ARFID is a serious feeding disturbance that requires early recognition and care to support growth, nutrition, and social difficulties. And I want to thank my multidisciplinary group of passionate providers.
That was absolutely fascinating. Thank you so much, Dr. Bern. And for our third speaker, I'd like to introduce Janelle Smith. Janelle, would you like to share your slide?
Absolutely. Thank you.
Here, MSRD CEDS is a registered dietitian nutritionist with expertise in both gastrointestinal disorders and eating disorders. She works outpatient with UCLA Division of Digestive Diseases, specializing in gluten-related disorders and avoidant and restrictive eating patterns in patients with digestive disorders. She's a certified eating disorder specialist through the International Association of Eating Disorder Professionals and has worked in all levels of care with eating disorder patients. She's passionate about training other dietitians to better care for these patients and is co-founder of the EDGI training program, as well as leader of the Disordered Eating Workgroup in the Academy's Medical Nutrition Therapy subgroup, Dietitians in Gluten and Gastrointestinal Disease. Janelle, welcome.
Thank you so much. I think a lot of my bio explains some of my disclosures. I don't receive any funding other than my individual ventures and employment. But I do want to mention that I have lived experience with celiac disease and disordered eating. And so a lot of my approach to these disorders is informed by that. So my experience may not be the same as your experience. And like Dr. Satherley mentioned, there's really a lack of evidence to guide us on what actually is the best way to approach this for different populations. My own lived experience is informed by several privileges that might shelter me from negative situations in this world. And so what's right for me may not be right for everybody. Just want to put that out there. So we'll talk a little bit about nutrition therapy for these overlapping disorders in terms of preventing disordered eating, nutrition counseling beyond the gluten-free diet, and I'll also give some of my some resources that I know about for support. So the problem is that diet culture is almost enmeshed with the gluten-free diet. So often it's become so popularized through being sold as a weight loss or health diet, not necessarily for people with gluten-related disorders. And I don't know about you, but these are actually 4 things that people actually said to me in my first year of being diagnosed, when I felt like my world was turned upside down and they were just really missing the mark in terms of they were trying to be supportive, and what just was not what I needed to hear at that time. Seeing this as a nice health benefit for your weight doesn't quite match the severity of the medical trauma from symptoms prior to diagnosis, and then a lifelong strict medical gluten-free diet rather than a flexible gluten-free diet that other people may follow. Did that, okay. As others have mentioned, often our interactions with a dietitian in gluten-related disorders can involve avoiding gluten, getting good nutrition, and normalizing weight. And while I certainly address those things as well in my visits with patients, we really need to be careful of the messages that certain people are really susceptible to of fear, perfectionism, and control. And the truth is that there is limited control that we have over our bodies, as we have all experienced from being diagnosed with a gluten-related disorder. I don't know that anyone chose it and checked a box and said, oh, sign me up for that one. It wasn't necessarily a control or choice on our part. as has been mentioned as well, there is an increased risk of clinical eating disorders in patients with celiac disease. But I agree with Dr. Satherley. I think this is an underestimate because most of the studies have not looked at the wide variety of disordered eating spectrum. But Dr. Satherley herself did look at it in 2015 in the context of all GI disorders. And this is maybe more what I feel like I see in clinic, including people with gluten-related disorders, the 23 to 44%. Celiac disease, just one new research study came out about the tool that Dr. Satherley mentioned that she developed that needs more research, but it was very interesting to see that maladaptive eating seemed to be related to the diagnosis being very recent, having continued GI symptoms, as well as the perception of quality of life. So it's like when everything is struggling, relationship with food struggles. Dr. Bern kind of went over this vicious cycle on the left of having GI discomfort for many people that leads to food avoidance and can lead to altered hunger cues, appetite, feelings of early satiety, early fullness, discomfort, pain, and that can alter food intake. And in ARFID, it decreases food intake, but in other eating disorders, I absolutely see GI discomfort lead to increased food intake or altered timing of food intake. So I want to kind of broaden that in terms of that cycle. Then on the right, we have kind of a more weight-related or morality-related cycle of feeling guilt or shame around one's body or one's diet, wanting to restrict or control food intake to solve that problem or feeling, then getting fatigued from that control, losing control, maybe eating the things that were deemed as bad or off limits, and then experiencing that guilt and shame again that just continues to feed itself. So in nutrition therapy, as Dr. Satherley has mentioned, there's not evidence-based. What are we supposed to do in someone with celiac disease or another gluten-related disorder and disordered eating or an eating disorder? But this approach comes from my clinical and experience and training in treating eating disorders in general, that it can be very helpful to use language from the dietitian. It's very important the dietitian changes their language to reframe the relationship with food. Good and bad are two examples, but I feel like safe and unsafe is a really common dichotomy that shows up in gluten-related disorders that can exacerbate anxiety and disordered eating. We can explore the different fearful food situations based on the evidence that we have available in terms of gluten contact. And we also need to explore how the two are related, how GI symptoms are related to body image, as well as desire to be healthy overall, because really these two get inextricably linked. And I find that if we don't address them both, we're not actually addressing the root. So my recommendation in preventing disordered eating, especially someone who is newly diagnosed, or maybe for parents who are concerned about their kiddos, don't make the gluten-free diet about weight or morality. The gluten-free diet is something that the body needs because the body has a different need based on this new diagnosis. This is not a weight gain or a weight loss diet. And this is not about being a good person, being a bad person, or being an overall healthy person. Yes, a gluten-free diet can improve someone's health, but it's not exactly about eating more vegetables at its core. We need to create environment of enough food options. I think inherent in the gluten-free diet for disorders is this feeling of scarcity, right? And that's traumatic for our body. Our body doesn't like to feel food scarcity. That kind of is a primal urge for us. So we need to make sure that we have enough food options. They're going to be different options than before, and that's going to be a difficult, uncomfortable change, but at least it needs to be enough. It needs to be available. And so including favorite foods, developing new favorite foods, I think is very important to preventing disordered eating. And throughout it all, we need to okay all the feelings. This is a grieving process, an up and down process. And I absolutely think that psychological help can be, and community support is really necessary in that. So here's your dietitian's prescription for good nutrition. Remember that good nutrition is individualized to your needs. There's not one healthy diet for everybody in this world. It is flexible. It can be different based on whether you're working or at school or on vacation. It's tasty. It includes joy. It's not just food as fuel, but it also provides enough fuel. We can't have a healthy diet if we don't have enough energy. We might think that, oh, all the foods in our diet are perfectly healthy, but if it's not enough energy, it's not fueling our body. So there's a couple existing frameworks in nutrition therapy that we can use in our practice. One of them is intuitive eating, which was first developed by Evelyn Tribbley and Elise Resch. And these are the 10 kind of cornerstones of intuitive eating, not related to gluten-related disorders, but I think we can really apply them in GI disorders. Our medical needs are not about good or bad or healthy or unhealthy. If we can unlink, our feelings about eating a gluten-free diet, that can be really helpful. We need to have food available to eat when we're hungry and work on feeling, stopping, respecting our fullness when we're full, unless there's another condition that complicates that, like in the case of ARFID. Discover the satisfaction factor. I'm going to talk a lot more about. Cope with your emotions with kindness rather than with food. It's very common to self-soothe with food, and certain foods that taste really good and alter our mood are more likely to impact our body in different ways. So having other coping skills is really important. Respecting your body and honoring your health, I think, is the core of the gluten-free diet for someone with a gluten-related disorder. So how can we come about at that with compassion rather than fear, control, etc. So in terms of the satisfaction factor, remember that our body needs all of these macronutrients. When we eliminate bread or gluten-containing products, we should not eliminate carbohydrates or complex carbohydrates as a food group. Otherwise, there's going to be a really big shift physiologically in how our body uses nutrients. So one example of combining macronutrients for feeling satisfied would be, let's say you just had an apple for a snack because you think, great, that's gluten-free, safe, unprocessed, healthy. I don't know what you think about an apple. You're likely to feel hungry within 30 minutes just based on how many calories it has and what its nutrient composition is. If you add a fat or protein like peanut butter, you're most likely to feel nourished for longer and satiated. Now, let's say you add a complex carbohydrate, because apple is carb, but not exactly complex. So you add gluten-free crackers, and now you're satiated for 3 hours, 3 or 4 hours. Wow, look at that. Or maybe You could do the same with cookies. Let's say you only had a cookie because you've been really craving that cookie that you aren't allowed to eat because it contains gluten. You may feel hungry 30 minutes later. If you combine the cookie with peanut butter, great. Cookie, peanut butter, and apples, even better, more likely for your physical satiety.
Excuse me, Janelle, you have 3 minutes.
Thank you. Here's another example of what we can add when dining out or in other situations to add satiety in terms of adding complex carbohydrate, fat, flavor, protein, and joy. Then we have mindful eating, which is the practice of being present while eating. This means not eating distracted, non-judgmentally observing what's happening in your body, how things taste, feel, and what the effect is. So an example might be like, I ate this salad with no carb, and it was really crunchy. I loved it. And then I feel hungry, an hour later. I don't like the way this gluten-free bread tastes as much as the other bread. I feel sad, and that pit in my stomach kind of alters how much my hunger is. So now I don't really feel like eating. Those would be examples of using mindful eating to be more aware of your experience with food. And structured eating, like Dr. Bern had mentioned, can be really helpful to reduce the mental load of decisions about food, to restore hunger fullness cues, balance eating behaviors, minimize the digestive load in each setting, so minimize GI symptoms, and rehabilitate the body's physical needs. Finally, harm reduction is a different approach regarding respecting autonomy, readiness, and motivation. And there's non-judgmental permission to act on urges and can actually paradoxically increase safety behaviors. So I'm going to briefly put up these slides of different support resources that I've found, and I hopefully will be able to distribute them to all of you afterward as well. So we've got a few podcasts, some reading and books, and some groups that offer online support groups, mentorship programs, trainings, etc. And then here's some more learning resources for healthcare providers, if there are any out there that would like to learn more about this overlap. I'm happy to answer any questions by email as well, and thank you.
Janelle, thank you so much. Thank you to all three of our speakers. We are so lucky to have you with us today. We're going to jump now to the Q&A. So the three of you could come back. Thank you. Okay, so let's start actually with a diagnosis question, so at the beginning of the beginning, for Dr. Bern. Dr. Bern, does ARFID or disordered eating affect any of the diagnostic tests or procedures associated with celiac?
Once you have celiac disease, I think the question is, ideally, when you have celiac disease, you'll be able to go on a gluten-free diet, but continue to eat a varied diet that doesn't impair you in terms of health, in terms of the diet content, in terms of social concerns. And so if you're finding that you're really still having significant difficulties with eating related to, like I said, a very narrow diet, social difficulties, then the question is there something else going on? Do you have ARFID? Do you have celiac disease that is not fully treated, and therefore you're still having GI symptoms that need to be addressed? I guess that would be the answer.
Excellent. Thank you very much. And a related question to that, if there's an answer to this, which comes first, Dr. Bern, ARFID or celiac? The question we'd like to make sure that's clear.
Yeah, I mean, I think as I talked about in the slide, I think it can depend. ARFID more commonly occurs earlier in life in children or adolescents, but it could occur at any time. And so you may have ARFID, and then at some point in your life, you develop celiac disease. And so you're still addressing the ARFID, and now you have to be on a strict gluten-free diet. Or you could have celiac disease, and you have developed sort of a fear of, developing GI symptoms when you're ingesting gluten. And in the susceptible individual, that may then turn into ARFID because now you're afraid to eat, and you have celiac disease. So it can happen either way.
It's a two-way street. Okay. Rosie, Dr. Satherley, did you want to add anything there? You could.
No, I think what Dr. Bern said is absolutely right. And some of the complexity comes from that, as we spoke about the touch points in anxiety, that pre-diagnosis when you've got symptoms and you individually might link them to food, but you don't know what they are. So you might avoid food as a safety behavior, and it complicates that relationship.
Thank you. Thank you so much. And Dr. Satherley, let's see, how can we phrase it? Do you think that the DSM-5 criteria, which is the diagnostic coding criteria for those who might not be familiar with that acronym, think that criteria for eating disorders has caught up with those patients and those people who present with chronic conditions and autoimmune diseases like celiac disease?
So my very short answer is no, I don't. So for those who don't know, so the DSM criteria focus on your clinically significant eating disorders, so anorexia nervosa, bulimia nervosa, all your sort of the eating disorders most people think about, and ARFID has been recently included, which is really promising. But the problem with DSM is it doesn't account for those complex environmental factors that are really important in gluten-related disorders. So the shame, the food availability, the gastro symptoms. The other problem with the DSM is that whilst some people gluten-related disorders might have a clinically significant eating disorder, it doesn't capture all of those with sort of the yellow box I was talking about, the disordered eating behaviors, the hypervigilance, the preoccupation, that is also very harmful to people with gluten-related disorders. And I think that's a real problem with the DSM, because it's actually the yellow box is that prevention we want to be doing to stop people going on to develop clinically significant eating disorders. So no, I don't think it has caught up yet.
We can be hopeful though.
Yes.
ARFID is the new kid on the block. Would you say that's fair, Dr. Bern? ARFID being the new kid on the block?
ARFID is relatively new. The DSM-5 was published in 2013, so it's just over the last 10 years. Previously, I think it existed, but it was categorized more as eating disorders not otherwise specified. And then there was a category for younger children with feeding problems.
Thank you so much. Okay. Janelle, in children with pre-existing disorders who've been diagnosed with celiac disease, parents are often asking, now they're taking out a quote massive food group, how can they do this without triggering further issues? And anyone else who'd like to comment, Dr. Janelle, would love to hear from you. How can they navigate this at the beginning of their diagnosis?
Yeah, it's very challenging in terms of food accessibility and food scarcity because the available carbohydrates, or if we're talking about that food group in the general public, may be limited. However, I think it's very important to convey that the gluten-free diet is not a low-carb diet. It does not involve eliminating carbohydrates. It does not eliminate any food group. There are many, many gluten-free starches, carbs, sugars, sweets, the whole gamut of foods. It's more about having access to them. And I think parents, family, friends can really play a role in making that more accessible, because sometimes the burden is only on the patient. And we really need our friends and family to advocate for us as well.
And sort of related to that, moving into the school system, Janelle? Specifically when they're at school? Or actually, I should ask Dr. Bern or Rose, did you want to make an additional comment there?
Okay. And the only thing I would say is that again, I think there are multiple parts to a healthy diet. So fruits and vegetable and proteins. And so there's a lot of other things to focus on besides the gluten. And, one of the goals is to try to make food fun, whether it's, creating recipes, connecting it with positive social experiences. And that doesn't have to include gluten.
And, do you find in the school setting that it's particularly difficult? What's it like for the school team encouraging a child with these comorbidities?
Well, with a 504 plan in place, which you might be able to find out more about through NCA, it is actually legally required that every child have an appropriate replacement carbohydrate source. So nutritionally, they cannot serve your child a salad with no starch in it. They really do have to provide a safe gluten-free starch option because starches are an incredibly important part of our diet and fuel for our body. Not the only nutrient that we need, but a very, very important one that is vilified, I think, in our current pop culture. So getting a 504 plan in place could be helpful. Also working with teachers, school staff to make sure that your child has alternatives available at all times, because you may not be able to anticipate when somebody decides to share their cookies or cupcakes, and it is really helpful to have food available for your kiddo in the school setting.
Dr. Satherley, any addition to that, please?
Yeah, so I suppose I come from a slightly different perspective because I have no idea about the American school system, and the 504 plans sound incredible and I'm very jealous. I know I spoke a little bit about the iceberg tools and using that to speak with your healthcare team. Sometimes it's actually important also to wonder, actually, how is this affecting my child? I think sometimes as parents, we might assume things are happening for our child or interpret things incorrectly. Use those tools to ask them what's going on in school, what are the difficult things, and then you can use that to problem solve with the school.
Mm-hmm. And we similarly try to identify if a child is at risk for ARFID, to work with the school to make sure they're getting the supports they need.
Thank you so much. So we all know that there's an issue of potential weight gain on the gluten-free diet. Something that comes up in clinic, certainly within the adult setting. I know less about the pediatrics, but Janelle, so with that struggle of the extra salt, fat, sugar, and gluten-free foods, etc., that feeling of deprivation that can come on there, or that frustration, do you want to address that a little bit?
Absolutely. I think it could, weight gain is a stigmatized thing in our culture. But I would like to recommend changing the conversation to weight changes, because weight changes, body changes are very common both before diagnosis and after diagnosis. And they often are related to our body's changing needs, including maybe needing a gluten-free diet, or needing to hold on to body weight because the body has just gone through a period of intense stress. So acknowledging that weight changes are another thing that can feel out of control, I think is the root of that we're not in control of what we can eat anymore because we have to follow gluten-free diet. And now we're also not in control of what's happening to our body shape. And we may be treated differently or perceived being treated differently in our world because of how our weight changes. So in people who are predisposed to disordered eating, which is a lot of people, let's disentangle weight from the gluten-free diet. I don't think it's appropriate to discuss with any child honestly, in a healthcare setting, because most kiddos with a weight-related eating disorder report having medical trauma of being told by their healthcare provider to be worried about weight gain. I think working with a dietitian on your individualized needs is really important to having a balanced diet and to understanding the body changes that are happening. Certainly, if our diet is only composed of starch, sugar, salt, fat, we're going to see a certain body change in certain individuals. And so how can we balance that, and how can we disconnect it from the actual gluten-free diet?
Thank you. And there was one question related to this, a real quick a comment that most gluten-free crackers are not complex carbs because the grains are processed. Just as a dietitian's comment, anything you want to throw in there?
Yeah, so I think that processed and unprocessed is different than simple and complex. So simple carbs are sugars like lactose in milk, fructose in fruit, sucrose in table sugar and sweets. Those are metabolized very quickly in our body, like empty the stomach within 30 minutes, hit our blood sugar stream within 30 minutes. Complex carbohydrates, even if they are processed, take longer to metabolize and improve energy and satiety. Those that are less processed and or have fiber can also add even more satiety and health benefits. So even a gluten-free cracker made completely of potato starch is actually a complex carbohydrate nutritionally. One that is made of whole grain rice flour and buckwheat flour and added seeds is going to be kind of the next level of whole food or whole grain.
Thank you very much. So moving on to other approaches, psychology, and Dr. Bern, you might want to lead into this too. Are there any intergenerational approaches to eating disorders within families for either celiac or ARFID? Dr. Satherley, you want to start with that?
For ARFID, I don't know. For celiac, definitely not, because new interventions for celiac specifically don't exist. But when we think of the broader eating disorder literature, there are lots of family-based interventions for eating disorders, and they show huge promise actually across the lifespan. So even if you're an adult with with an eating disorder, family-based interventions show huge promise in supporting individuals with eating disorders. I hope to see this work in celiac disease soon.
Thank you. And Dr. Bern, did you have anything to add to that, please?
Yes. So in ARFID, I think a lot happens. I think a lot of times parents are so worried about their children that they, again, will feed them the specific narrow foods that the child is used to, and also often let them graze, which as a result, they eat all day long. And in the end, you end up eating less that way than if you ate in a structured pattern. So I think helping the family to understand the importance of structured meals is really, really important. So we talk about kitchen open, kitchen close. So you can, eat your meal and then you have time to get hungry again. And then also making the meal a family-oriented, low stress experience is really important. And both of those things will really help in terms of encouraging the child to want to eat.
So lucky to have the three of you answering these questions. I want to quickly throw in something to the psychology piece that was asked. We've talked a little bit about psychotherapy. Dr. Satherley, are antidepressants ever used for ARFID and also Dr. Bern?
I'm going to pass that one to Dr. Bern, because as a psychologist, I wouldn't prescribe antidepressants. I would use more the sort of talking therapies we talk about.
Mm-hmm.
So I would say that, again, ARFID is a relatively new diagnosis, and there's a lot of studies going on to, again, understand the best therapies. But to date, there's no medicines that are approved. Medicines can be used as an adjunct for mental health support. But specifically for ARFID, really looking at these different therapies, the structured meals, the food chaining, the cognitive behavioral therapy, those are usually the things they use.
Mhm. And I think we have time for one, maybe two more. So I'm just going to ask Janelle, regarding bulimia.
You said bulimia?
Yes, bulimia. If you could just quickly say what that is, and also online support groups for that in specific you'd like to share about it.
Would it be okay if I shared the slide of support while we are doing the Q&A? Just because a lot of people have been awesome. So bulimia nervosa includes the primary, I guess, behavior is compensating for food intake. And compensation comes from usually a feeling of guilt or that we've done something wrong. And that compensation or atonement can look like self-induced vomiting, passive vomiting, I have seen, excessive exercise, weight loss drugs, misuse of a medication like an ADHD medication, etc. And we do find, or there's been some evidence that actually, Melinda, I think you published about patients consuming gluten in order to justify a purge or a compensatory behavior, or even believing that eating gluten itself is the compensatory behavior, right? Well, if gluten causes malabsorption, maybe eating gluten will continue my weight loss or lack of weight gain. And this is a really difficult thing to disentangle. I think that it's usually, what I find works better is to separate weight from the gluten-free diet, right? That these are separate things. And some people are not ready to stop binging and purging. And if they're ready to take care of their health in any different way, perhaps binging on a gluten-free food is actually going to be better for their health. That's a really just one approach. But I think that getting eating disorder treatment based on the severity of the bulimia is really important, and having providers who are knowledgeable about how much gluten you can and can't eat, etc.
Thank you so much. And we are running out of time here. I could stay on with you all day. Is any last message that you don't think we've covered, Dr. Bern or Dr. Satherley? Just to finish up, do you feel like there's a message you'd like to deliver to the audience?
I think, to me, everything we've spoken about today, and it's nice having different professionals on the call, it really speaks to joining up our different expertise for the patient. It's psychology, it's gastroenterology, it's dietetics, it's everything, right? And from the health system I come from, we don't often get that. So I'd really encourage patients to shout for that. And if that sounds helpful, shout for what I would call integrated care or joined up care, because I think that's really important. And that seems to be what I'm hearing today.
Thank you so much. Dr. Bern?
I totally agree. We talk about it takes a village, and I think, these are complex presentations, and I think multidisciplinary support is very, very helpful. The only other thing I wanted to add is if you do find that your diet is really missing food groups, to make sure that you're taking a complete gluten-free multivitamin every day, not a gummy, but a complete multivitamin, because that will help provide you with vitamins that you may not be getting otherwise.
Thank you so much. So I'm really hearing that the key here is support. Like, don't do this by yourself. Reach out, and let's put this on the front burner in every clinic and research studies. So I'm going to hand it back to Lee to end the video today. And thank you again to our amazing speakers.
We hope you found this webinar educational and helpful. Boy, I certainly did. There was an awful lot of wonderful, wonderful pieces in here. And we'll be hosting webinars in the fall, so stay tuned for more information that becomes available. And you'll see that on the National Celiac .org website. And until then, from all of us here, see you next time and stay well. Bye-bye.